We'll go on to the last talk, which is by Bob Orlowski from the MD Anderson, and he's going to talk to us about timing of transplant for multiple myeloma.
Well, thank you very much for the invitation to speak here, and I'd also like to congratulate the organizers because it seems like this meeting gets bigger and, more importantly, better every year, and hopefully that trend will continue. So I'm going to talk to you, as you know, a little bit about the timing of stem cell transplantation. And first of all, just to give you some of the background very briefly about the benefits of transplant, we know that even though there are many novel agents that are now available, some of which you saw from Dr. Vij and Dr. Chim, in the past, when chemotherapy alone approaches were compared to chemotherapy plus transplant, there was a general consensus that using high-dose therapy was of benefit, although, of course, this was before the novel agent era. Overall, meta-analyses have shown that autologous transplant versus continuing combination chemotherapy had a benefit in terms of progression-free survival, as shown here, and also, although a little bit more modestly so, nonetheless a benefit overall in the overall survival as well. Another question that's been asked over the years is whether a single or a tandem autologous transplant is best. Again, a number of studies that I'm not going to review all of them for you here, but one in particular, the IFM study shown here, did reveal that a tandem transplant was of benefit compared to a single autologous transplant, although subgroup analyses suggested that the second transplant was of benefit predominantly for people who were not in a CR or VGPR after the first one. And right now, really, that represents a pretty small patient population if you use novel agent induction therapy. Consolidation is another option that you now do have after transplant. There aren't yet any randomized studies that show that consolidation versus no consolidation after transplant is of benefit, but certainly there are nice studies like this one from the Italian group that show you that using novel agents in combination after transplant can improve the response quality, possibly achieve molecular complete remission. And we all think that certainly in analogy with other diseases, if you can get so much of a cytoreduction, probably there will be benefits in terms of progression-free and overall survival as well. In addition to consolidation, you can do maintenance therapy. There are data supporting the use of thalidomide. The most recent data, of course, are in favor of lenalidomide, and I've summarized the two major studies for you in this and the next slide. One of the U.S. intergroup studies that looked at this compared placebo after transplant to lenalidomide after transplant. And you can see that there was a benefit in time to progression of about a year and a half with fewer deaths as well, so a better PFS as well as a better OS. One of the concerns, of course, has been, unfortunately, that there is an increased risk of second primary malignancies, although some of the later analyses suggest that perhaps that is not any longer the case. So getting back to the original question here, what was the question was whether we should do, I think, either early transplant or delayed transplant. And one of the most commonly quoted studies that looked at this was, again, a French trial where patients were randomized either to undergo induction therapy and early transplant. Remember now, this is in, if you will, the dark ages when regimens like VAMP were used, or to try to delay transplant until the time of relapse. What was seen here in the Consort Chart is that there were about 200 patients that were randomized, and ultimately about 75 patients completed their chemotherapy group, and about 70 patients also completed the transplant. If you look at the overall survival, you can see it doesn't take a statistician to note that the curves are very overlapping, which means that there was no difference in overall survival whether you did transplant as part of the initial therapy or whether you did initial therapy, waited until relapse, and then did a salvage transplant. One of the benefits maybe of doing an earlier transplant was quality of life, and they measured this in a number of ways, but one of them was with this term that they called TWIST, which was time without symptoms, treatment, and treatment toxicity. And you can see that there was a longer time without toxicity if patients got transplant versus those patients who did not get stem cell transplant. Longer follow-up was published a few years ago about this, which again bore out the initial conclusions, showing that overall survival was not substantially different. Event-free survival was a little bit different, but did not really reach statistical significance with a median follow-up at this point of 10 years. And again, the improved quality of life was maintained even with longer follow-up. And certainly if you can get the same outcome with better quality of life, that's a very valid endpoint. One of the questions that's been answered or asked more recently is, should we do early harvest and late transplant? So not everybody agrees that transplant should be used up front, and one of the studies that looked at this a few years ago was from the Mayo Clinic. They collected stem cells from patients within 6 months of diagnosis, usually after VAD induction. The study is about, as you can see, 13 or 14 years old. And then they did transplant at progression, and you can see that there was a median of 38 months until the time of transplantation. And the median survival in this patient population was about 5 to 6 years, which is not unreasonable in a time when novel agents were not yet available. And so their conclusion at that time, which is quoted here, was that the underlying biology of the disease has a greater impact on survival than the timing of stem cell transplant. Other studies, or at least sub-analyses that may shed some light on that, you all know about the ECOG study that looked at lenalidomide with high-dose dexamethasone versus lenalidomide with low-dose dexamethasone as initial therapy for myeloma. And you know that although the response rate was better with the high-dose dexamethasone, the progression-free survival and overall survival were a little bit better with the low-dose dexamethasone. And with longer follow-up, those trends were really borne out. They also performed a landmark analysis looking at 90 patients who went off of induction after 4 cycles for stem cell transplant. And you can see that their overall survival at 3 years was 92%, whereas patients who continued on chemotherapy past the initial 4 cycles had a 79% 3-year overall survival. So not a randomized study, but nonetheless data that suggest that perhaps earlier transplant may be better. Further light, I think, was shed by David Siegel in this analysis as well, where they showed just in subgroup analyses that both in younger patients, these were defined as less than 65, you can see that the group that got the early stem cell transplant in the dotted line did better than the group that did not get early stem cell transplant. The previous analyses, you could argue that it was a mixture of transplant eligible and ineligible patients, so maybe that changed the outcome. Here you've got all patients that would be transplant eligible, and the same thing was true for patients that were 70 or older, some of whom would be candidates for transplant in the US, but might not be candidates for transplant in Europe. Shaji Kumar also published an interesting case control study recently where they looked at 290 patients that were treated with an IMiD-based induction regimen and about equal split between thalidomide and dex or lenalidomide and dex. And then they looked at early transplant versus late transplant. Early transplant was defined as occurring within 2 months of stem cell harvest, and it had to be within 12 months of diagnosis of myeloma, whereas late transplant occurred after 12 months. And you can see that the early transplant group was a median of 5 months, whereas the late transplant group was a median of 44 months. So really a big difference, because in some of the previous studies, the differences between early and late were much more modest. The 4-year survival here was, interestingly, identical in the two groups, early or late transplant, at 73%, and that was true whether they got thalidomide and dex or lenalidomide and dex, although maybe time to progression after transplant was a little bit better with early versus late, although there was no statistical significant difference. I think ultimately what we really need are data from a large randomized phase 3 study, and some of you may be participating in this trial. MD Anderson is. This is led by the French myeloma group and the folks at the Dana-Farber, and patients are being randomized to 3 cycles of induction with lenalidomide, bortezomib, and dexamethasone. They all then get chemomobilization. Half of the group then goes on to stem cell transplant, followed by additional maintenance therapy, while the other half of the group goes on to just consolidation and maintenance, and the transplant is delayed until the time of progression. And when we know the results of this trial, I think we'll be much better informed about what the right timing of transplant really is. I would suggest, though, just in terms of throwing something out, and Dr. Vij covered part of this, that perhaps achieving complete remission, especially if we can achieve molecular complete remission, might be really the way to try to triage these patients. As you saw from his presentation and from these data here, a number of studies have shown that complete response, both prior to transplant as well as after transplant, is associated with a good long-term outcome. And here are the data for CR after transplant, where people in that category do much better than people who have partial remission or certainly versus stable disease. Again, from the French in the IFM studies, they were able to show the same, where complete remission prior and after transplant was of benefit. And this has also been true in Asia, where a couple of years ago, the Korean myeloma working group showed also that CR before transplant was a predictor of good outcome, and CR after transplant was a predictor of good outcome. The same we know from Bart Barloghi's data at Arkansas, where achieving a complete remission and, of course, maintaining a complete remission identifies patients who are in the best subgroup. And we have some limited data from MD Anderson that also suggests that complete remission is of significant value. Michael Wong a few years ago did this analysis where they were able to show, albeit in a non-randomized and with relatively small numbers, that patients who achieved a complete remission with chemotherapy alone actually did just as well as people who achieved a complete remission only after chemo plus a stem cell transplant. Other considerations, of course, that you need to have include access to novel agents. Dr. Chim mentioned this. Transplant is certainly a great way to achieve cytoreduction and especially complete remission if access to novel agents is limited. And the cost of chemotherapy versus transplant needs to be considered as well, because transplant is certainly cost-effective compared to long-term therapy with novel agents. And also the benefit is that this may allow you to reserve some novel agents for later in the disease course, although whether that's a good thing or not is a separate topic for debate. So the conclusions that I would leave you with are that we certainly need randomized trials like the IFM Dana-Farber study in the novel agent era that compare doing early transplant versus delayed transplant. The available data that we have, which are very limited, oftentimes not randomized, and some of the data are not in the novel agent era. Nonetheless, they do not suggest that patient outcomes are compromised by reserving transplant until the first relapse, especially if they can achieve an excellent response quality with their induction therapy. I think the one concern that I always have is the possibility that if we use novel agents up front and get an excellent response quality and depth, and then we follow that with consolidation and maintenance, that maybe when those patients have relapse, their disease will be much less sensitive to melphalan-containing approaches, and that therefore the benefit will be lost. In the absence, therefore, of data at this point, what I do in my routine clinical practice is I talk to my patients, and for those that do not achieve a complete remission, I think moving on to stem cell transplant to get that is very reasonable. For those people who achieve a complete remission, I have a discussion with them about their goals. I tell them that we don't really know what the right step is at this point. I give them the option to collect stem cells and store them away for a later transplant. But I still, if they ask me what I recommend, I still recommend early transplant versus saving it for later because of this concern that we're going to lose the benefit of transplant at the time of relapse after novel agent therapies. Thanks very much, and if there's time, I'm happy to take questions.
Okay, I think we have time for questions for 5 minutes, so I will invite the panelists to come up to the podium. And for those who have questions, please move forward to the mic and identify yourselves. Yes.
Dr. Shomo Bhattacharya from India. My question would be, what is the role of bendamustine in refractory myeloma?
Well, bendamustine. Well, actually, I think that if you actually do a literature search, there is several. I've done it. I've used it. Well, apparently one patient respond quite well. The other few actually respond not so good. So actually, in those cases, in my personal experience, I combine Velcade together with bendamustine empirically. So actually, there's no data at all. So I think that, in my view, my experience, bendamustine is not terribly effective. Probably because my case, actually I treat my patients who are actually in a advanced stage. They have their late relapse from novel agents, transplant, etc. So I don't see any big studies on the use of this drug in early stage of a disease. I'm not sure whether the other speakers may have experience.
Used a fair amount of it. Obviously, there's data even in combination with Revlimid and also in combination with Velcade. It, I think, produces faster cytoreduction than does Melphalan. Whether it's a better drug than high-dose Cytoxan, I can't say, though it may be less causing alopecia, perhaps.
Thank you.
Maybe I can ask a question for Dr. Vish. In terms of the triplet therapy, do you think a triplet containing 2 novel agents or just 1 novel agent with a alkylating agent would be the way to move forward? And what are your thoughts about, in fact, quadruplet therapy, which some groups have been trying to study?
Sure. Obviously, there's no mature randomized data of Velcade Cytoxan Dex, which is the common non-novel agent containing triplet, versus Velcade Revlimid Dex. The data in terms of depth of response seem to be similar. I think that certainly 4 drugs are probably not ready for prime time, though there was a data set presented by Palumbo at ASH, which was a little complicated, where 4 drugs followed by maintenance had a survival advantage. I'll turn it over to Bob, what he would think.
I would agree, and there was the evolution study which looked at 4 drugs versus 3 drugs, although the patient numbers in the groups were relatively small. And at least my take on the data was that the 4-drug regimen was more toxic, but didn't really seem to be of greater benefit. My personal feeling is that 3 drugs has maxed out the benefit from a cytotoxic perspective, and that what we probably need to do is add an antibody at that point.
I also have a question about the early versus late transplant. In the Vermont study, if I remember right, patients were allowed, if they had progressive disease and were randomized to the late arm, they were allowed to get transplant earlier because they had progressive disease, which kind of skews the data on both arms and makes that a little less clear about the advantages, I think.
Well, no, you're right. It turns out that I think the difference in timing of transplant on those 2 arms is only about 6 months.
Exactly.
And so that's why I showed some of the other
Right.
more recent, although just case-controlled data, that do show a big difference between early and late in terms of the actual timing, and yet the outcome is the same. But you're right,
Right.
that's a very valid criticism, but it is one of the only randomized studies in the area.
No, I agree. It's just a little confusing.
Yep.
And I guess my other question is for the panel. If somebody has standard risk disease and has an NCR, this is probably a little premature, but it was brought up about maintenance therapy here and there. Would you actually put them on maintenance, or has a CR, or a molecular CR, sorry, I phrased that wrong. Would you put them on maintenance therapy or reserve it for later? And this is, there's not data for this, so this is theoretical, right?
As a guest, I'll defer to the host.
Actually, am I correct that what else, if a patient achieves a CR, whether we should put the patient on maintenance versus what?
Versus no maintenance. If they have a molecular CR or a CR and have standard risk disease.
Well, it depends on the side effect of the maintenance. If there's, I think if the side effect is low, then I prefer to put the patient on maintenance therapy, because you see, actually, every now and then we come across patients who relapse. They actually know biochemical M protein. They turn hyposecretory or even non-secretory. So I'm supposed there are actually clones, although I don't know how prevalent it is. There are actually clones, or actually the original clone or multiple clones that may actually turn from a secretory myeloma to a non-secretory myeloma. So actually we don't know which one is which. So I prefer, if the maintenance therapy is actually with a very low side effect, relative side effect, I prefer. Yeah, but it's not evidence-based.
I mean, I think for me, the big question would be, what is the measure of molecular CR, and how deep
I don't have the answer to that.
is that molecular CR? If you're talking about a 4-log reduction, which is great, but there's still lots of myeloma,
Right.
then I would say maintenance is probably appropriate,
Right.
although we don't have any data. If you're talking about a 10-log reduction, then maybe I would say leave the patient alone.
You always worry about selecting out resistant clones with the maintenance, particularly in those patients who have a very, very, very good complete remission. I'm sorry to cut off the panel, so I'm sure there are lots of questions to be answered, and I'd like to thank the panel for an excellent discussion today on multiple myeloma, and certainly the chair, Dr. Weber and Dr. Chang. There will be a luncheon right next door, to my right, to your left.